welcome everybody. Thanks for sticking around for this Monday afternoon session. It's great to have you here. I am really delighted to share the stage with some amazing people working in the telehealth space for this panel, Structuring the Future of Telehealth, Evidence-Based Care, and Technology. My name is Navar. I'm an associate professor of cardiology at UT Southwestern Medical Center. I'm also the volunteer lead for the Heart Association's Doctors with Heart program, which we'll tell you more about at the end of this session. I'm joined on stage by four amazing people working in the digital technology and telehealth space. Dr. Mike McConnell, Chief Medical Officer at Tesseract Health and Professor of Medicine at Stanford University. Barb Fagan, Executive Director of Business Development and Chief Change Officer at Chanl Health. Zainab Magdon-Ismail, she's the EVP of Healthcare Operations and Partnerships at Moving Analytics. And then finally, Craig Beam, Chief Financial Officer, Worksite Labs of the American Board of Telehealth Expert Panel member and the past AHA Chairman of the Board. Thank you all to our panelists for joining. So just to sort of kick us off, I think the COVID pandemic, as we all know, sort of took a slow adoption of telehealth and ramped us up, really quickly. And all of a sudden, something that had been really happening around the fringes is now moved to mainstream. So let's talk a little bit sort of, since the pandemic, and maybe we'll start with Barb.
Great.
Now that telehealth is sort of here with us, how do we continue to make providers and patients comfortable with it, and where do you think we're going with telehealth next?
Wonderful question again. I think patients want to use this different technology. I think it gives us an opportunity for patients to receive care when they want, how they want, and where they want. What I've sort of run into is still we have a lot of clinical staff and providers who are incredibly resistant to doing this. So I hear that we've always done it this way, or we've all heard that. Or we hear things like, our patients connect with us. And so how could virtual care, do anything the same or better? Well, I'm here to tell you it can. Because what I tell everyone, it's not how you connect, it's that you connect. And you can do that through virtual technology.
Mike, why don't you sort of jump in here? Tell us sort of your thoughts on where we're going in telehealth. How do we get people to keep up or sustain this momentum?
So, yeah, I have lots of different perspectives on this. I still do part-time preventive cardiology, and so I've always been very enthusiastic about more frequent time points to check in, rather than the usual wait. See somebody 6 months a year, and their blood pressure's been out of control, their lipids are, So I've talked to patients a lot about could we have more frequent checkpoints. Telehealth is a perfect way to do that. I mean, interestingly, my clinic experience has been a lot of people like coming back into clinic because they really value, somebody jokingly said it's a bit of a placebo effect of putting the stethoscope on, listening to everything and saying everything sounds great, but there is a very strong positive reaction that people have from that. So one of the questions, a couple of things that have come up is how do you provide both the patient and the provider more of a sense that there is a physical exam, or you're checking more than just talking over the phone or over the video. So the other hat I've worn over the years, so I was at Google and Fitbit and Verily for 7 years, and how do we leverage all these technologies that we developed to make people feel like they can collect a lot more meaningful data from home, which is certainly possible, and then really feel like when I say everything sounds okay, that it's not just because you look fine on the camera, but that we've actually measured some important health signals. And then the one other thing that came up is, I had a patient who moved to New York and still wanted to see me, and like legally he can't, so he happened to be coming to Stanford for a work trip. So we did a telehealth while he was at Stanford because that was now legal. But so it's breaking down some of these barriers would be great.
So speaking of barriers, Zainab, your company is working on using technology and innovation to help kind of improve inequities in care and innovate in that space. Tell us a little bit about what you're doing at Moving Analytics.
Sure. So the basis of our program is to provide virtual cardiac rehab for patients, very similar to what Chanl does. Some of the things that we're working on is sort of system level issues. So we're working with providers to cover telehealth services for virtual rehab, make it more affordable. Payers is what I meant. Some of the payers have been very interested in doing things such as waiving copays. So we know that the typical barriers for patients to go to rehab often are cost, inconvenience, travel. Those are the top few. And so from a payer standpoint, we've been able to eliminate some of those barriers. We're also really looking at accessibility, so virtual rehab, providing technology, so smart devices that are Wi-Fi enabled with data plans so that we can access those patients who don't necessarily have the ability. The other thing from a systems perspective, and we talk about some providers having a little bit of angst about sending their patients to virtual care, is one of the things that we found as a challenge is just having systematic referral to rehab, period. So we're looking in various communities, what are the rates of rehab? Does anyone in the audience know what the average rate of rehab is in, let's say, New York or Illinois? Go ahead. 5%. So we're doing a little bit better than that, but completion rates are around that. It's less than 20% of patients go to at least one session. Completion rates are lower than that. And I was at a payer, our rates were 16% enrolled for even one session, and then 2% of people completed. So how do we systematically...
There's a lot of AHA science around how the outcomes are improved through compliance through rehab, by the way.
Exactly.
That's an important issue.
So how do we get that in the EMR? How do we get it systematic that patients are offered rehab, and then we have a whole variety of options for them to choose from?
I think it's certainly an exciting time, and I hope that we can continue to leverage people's familiarity with videos on their phone and how to get onto a Zoom with their grandkids into improving access to telehealth, access to their doctors, and expanding into things like cardiac rehab. Particularly important as we think about disparities in access to health, because for a lot of our patients, transportation issues are a challenge. I've done telehealth visits with people at their job, and it's a lot easier to take a 30-minute break into a closet to have a telehealth visit, or I've even done telehealth visits with people in their cars outside of their workplace versus having to drive across town, wait for me to, wait to get checked in and all those things. So, I think this is about providing options to our patients. Now, Craig, I want to ask you a little bit about, some structural things in place that are helping both with some of this reimbursement issue, but also standardization around, what counts as a telehealth visit and what should be considered adequate for a provider to be trained in telehealth. So, talk a little bit about your thoughts around standardization here and what you're doing with the AHA and American Board of Telemedicine.
So I'm going to start with the barriers, because Mike pointed one out. One is credentialing across state lines, which a lot of the emergency orders allow physicians to practice across state lines. Those are all being rolled back. There's also significant pressure from commercial payers to roll back reimbursement for telemedicine. So my first telemedicine project was in 2005, which was a long time ago. There was a cohort of hemophiliacs in Central California that needed to go to UC San Diego. Once they had adolescence, the compliance evaporated. Got a grant, highly successful, papers published, and as soon as the grant went away, it ended. And the other one that I worked on in California was we had, when you pay your phone bill, 3 cents goes every month on everybody's phone bill for the TVs, the deaf transponders. Well, nobody was using those anymore, so there's been $270 million accumulated. So we said, let's use that money and hardwire all the rural hospitals and the FQICs and the rural clinics so they have access to high-speed internet. So we spent the money, we did that, and that was the end of it because there was no reimbursement for telemedicine. So the great thing about COVID-19, not that there's a lot of great things about COVID-19, is CMS said it's reimbursable. And the good news is CMS has said they're going to extend that through 2023. The issue for the commercial players is it has, whenever you expand access, guess what? People use the access. So especially in my area of Orange County, Memorial Care did not see a decline in the number of visits, but they got greater reimbursement because they were also doing telemedicine. So at the AHA, we were looking at the issue, and the American Board of Telemedicine came to us and said, you have a lot of experience around certification and credentialing people to do the things the right way, and you have the science to back it up. So we took that, we took over the American Board of Telemedicine, that's probably too strong. I don't know what the right word is, but AHA took responsibility, how's that, for that piece, and we're now starting individual certification, which is relatively new, and we were launching 3 areas. One is smoking cessation, so that's going to be counselors and psychologists and psychiatrists as a certification program. The second is mental health, which has probably had the highest adoption level, just again because of access to care. So there'll be a mental health certification, then a primary care certification. So those are going to be the initial ones. But I think we'll be looking at cardiac rehab, and stroke is probably the next one that's coming up, because that's a huge issue in terms of rural populations being able to have access to care. And the hope is to provide some science, some structure around the qualifications of people who are doing it.
Craig, you talked about wiring FQHCs and increasing access for the clinics. But what do we know, and this is open to anyone on the panel, what do we know about access to the right connectivity for our patients? One of the things that we've been thinking a lot about at the AHA's Center for Health Tech and Innovation is this concept of health equity, thinking about using technology to improve health equity, but also being very cognizant that technology can actually widen disparities because not everybody has access to these, smart watches or high-speed internet or an iPhone that can connect. So, anyone on the panel want to talk about, how do we address or pay attention to, or perhaps even improve disparities as it relates to telemedicine and access on the patient side to the technology that they need?
Well, I just had a quick thought, which was sort of from the device tech side. You'll see, and I think one of our innovator booths there talks about, they put just a cell phone chip and make sure that it's, works in the area of where the person lives. So there's no issue of Wi-Fi or paying for data plans or anything. It sort of, it solves both sort of technical literacy side and the technical access side. So there's some move to, having sort of automate the connectivity, address that part of it, but that's only one small piece of it.
I think it's got to be easy button. So my mother's 88, and during COVID we set it up so she could Zoom with the grandkids, and she only had to press one button, so that was good. But, this was in the Empire Health Plan. We launched a program, had great adherence for the first 10 days of the month, and then it fell off. We're all going, what's going on? And they were on minute plans, and the kids had gamed and used up all the minutes. So there's a lot of things that we don't, I have unlimited data. I never thought that people still bought, limited data, but that's what they could afford to do. So in that case, the health plan, which is a Medi-Cal managed care plan, paid for them all to have unlimited minutes. So I think there are solutions, but I think we need to be mindful. I think there's generational issues. Somebody like my mom, it's got to be absolutely easy and one button for her to do it, and it's counterintuitive. She doesn't own a smartphone. We bought a Chromebook for her so she could have a Chromebook to use. So I do think we need to be mindful of all these issues. I think some of those will fade. The millennials, I think, are really easy adopters, and then you get to my generation, which is sort of borderline, and then you get to my parents' generation. I think it's tough.
When I worked at Payer, one of the things that we took a look at is we had a fairly sizable Medicaid population, didn't have access to care, and we we essentially demanded of our providers who were vendors who came around with telehealth solutions to say, we'll work with you, but can we carve out, to Craig's point, to make sure that we have these teleservices and data plans available for our patients. So it's really engaging those conversations, and I will say most came back to the table. If they didn't have a solution, we worked on something together. So it's constantly keeping it top of mind.
I think part of this is also, as from the provider standpoint, is thinking about understanding the social determinants of health for our patients. One of them is home connectivity, and also, even privacy. Do they have a room that they can go to on their, and be alone and have a private conversation with their doctor? That may or may not be possible for all of the patients that we see. So being thoughtful about who we offer telehealth versus in person, and we may be dropping transportation barriers, but putting a new barrier in place.
I was just going to say, my own mother-in-law's experience at 86 is sometimes a hybrid solution is also good, where you can go in sort of 1 day a week, but the inconvenience of trying to go in 3 days a week, would be a barrier, and they wouldn't sign up. But she does some classes on Zoom, and once a week we'll go in for the face-to-face. So offering multiple options to sort of meet people where they are.
We also need to not forget that we have phones. We can still talk to people. You don't always have to see someone. So
A lot of people have access to email too.
Right. There's other
But
modalities.
the problem is reimbursement. The physician doesn't get reimbursed. So the places where you see rapid adoption are like Kaiser or Geisinger, where they own the insurance product. So they're economically incented to do it. And that's not how most of our systems set up.
But to your point, the phone does work, and oftentimes we get, and I know and I understand, but we get so fixated on the reimbursed part of it that sometimes we neglect giving care that we can actually provide. It doesn't have to be reimbursable. So a phone call, if you're doing a cardiac rehab virtual session and you're not able to do the actual video session, but you can pick that phone up, talk to that patient for 5 minutes, assess where they're at, and then move on. And that is valuable, not reimbursable, but incredibly valuable.
So Barb, thanks for the great comment. While you have the floor, don't put the mic down. I want to know a little bit more about what you guys are doing at Chanl Health, and talk to us about sort of hybrid systems of care.
So I'm glad you mentioned that as well. The hybrid model, really, in my lens, is a perfect model because you can still stay connected to the patients. You'll have that one-on-one visit. Might be something like they come in for that initial assessment, you do your evaluation, you set your exercise prescription, and then they may come back minimally 30, 60, or 90 days because we have to complete the ITP. But you stay connected with that patient through asynchronous, which could be through the technology. So we're delivering education through a platform. And earlier you mentioned a tablet. So creating a smartphone application, a tablet application, and a web-based solution so the patients can still access care through the web. So hybrid is really just offering the same core components of cardiac rehabilitation in a mixed experience that meets the patient where they're at, when they want to receive that rehab, how often they want to receive that rehab, and then those programs that are in the cardiac rehab deserts that we call, they may be 2 hours away from a bricks and mortar cardiac rehab. So if you can pull out of that toolkit, instead of them saying, there's no way, or there's no way I'm coming to your cardiac rehab, they might buy every positive thing that I said about cardiac rehab, but I can't drive 2 hours. I have children, I work, et cetera, et cetera. But then I pull out of my little toolkit and I say, what if we could get you to come one time, we'll do an assessment, we'll set up your plan, we'll set up your education, your goals, and then I'm going to have you come back maybe in 3 weeks, 6 weeks, and I'm still going to stay connected to you, whether it's asynchronous or synchronous, which we're being reimbursed for now. Could you do that? And it's really hard for the patient to look you in the eye and say, no, can't do that. Because it's a different, you're working with them and you're offering them a solution that they can still receive that really good care.
You know, in my practice, I often have patients successfully complete cardiac rehab and they tell me like, I've never felt better. Like, I feel great, they're all jazzed, they've been exercising 3 times a week at cardiac rehab and they're, you know, on top of the world. And they come back, see me 6 months later, and they say, well, I keep meaning to join the gym and I haven't been able to keep it up, and they sort of fall off. I'm wondering, maybe Zainab, if you can tell us a little bit about what do we know, or do you have any data or even thoughts about, would home rehab maybe make it easier for patients to keep doing what they're supposed to do after it's over?
Yeah, absolutely. This is what we're seeing. So just for the audience sake, our program involves like a smart scale, blood pressure, cuff, smartwatch, so either an Apple Watch, Garmin, that allows us to basically communicate with the patient and also see what they're doing in terms of exercise. And I think one of the things that's important for us, it's not just exercise. So cardiac rehab is a lot about diet, lifestyle modification, taking your meds, basic stuff. It's really simple care management. What we do is we follow the patients for 12 weeks, checking in with them every week, and then after up to a year, constantly checking in with them less frequently. But I think to your point, Anne-Marie, it's about knowing that there's someone there to have that conversation, to chat. We have an app-based tool, so we're checking in, and if we see the patient hasn't walked for 2 days, we're going to send them a little note. If they don't respond, we're going to give them a call. It's that type of gentle care management that I think makes a huge difference for patients. And then in terms of sticking with the program, we found that patients who enroll in virtual rehab have an 80% completion rate. So it's enormously high compared to our own patients who are in brick and mortar, who just, again, it's not that they don't have the best intention, it's just difficult to complete. And then in terms of outcomes, very similar to brick and mortar rehab, which is improved physical activity, weight reduction, better blood pressure control, and that, 2 big things in COVID were lower rates of depression and anxiety, so we measure that as well. And again, it's just about feeling better, having that buddy, and if you ever need someone to reach out to, we're there.
This is for you, Mike, because you've worked in this space in several different areas, but my question is around all of the devices that now we have for patients to wear or people to wear or use at home. Blood pressure cuffs and heart rate monitors and, you know, A1Cs and pill trackers. And, you know, how do we use these data to empower our patients, but also not overload the clinicians with data streaming into our EHR? And, you know, this sort of comes up with telehealth because a lot of times we are encouraging the patients that we don't see in clinic to maybe check their blood pressure at home or send us their weights. But how do we figure out how to integrate that in a way that is more frictionless for the patient and the provider?
Yeah, I think you asked sort of the, I don't know what the latest dollar amount, the $64 billion question now. It used to be 60.
We're at 1.9 billion.
Yeah, because I think, you know, there is sort of inherently this disconnect with the growing amount of data and capabilities of measuring health signals through our consumer devices, and you could argue, you know, blood pressure cuff sort of falls somewhere in between. It's, you know, FDA regulated, but it's really a direct consumer product. You know, we want to move to this sort of proactive, more continuous monitoring as opposed to the reactive, sporadic care. But our healthcare system sort of isn't designed historically from a reimbursement standpoint or from a personnel and the people side of it. You know, I don't have a short or quick solution for it. I think, you know, what most companies who are in that space are trying to do is to try to, you know, so I guess stepping back a little bit, there is now more reimbursement around setting up a remote patient monitoring and RPM service, but that typically means you have to have some degree of software and ways to bring in the data to sort of review the high priority data, and you often may need staff to be sort of the interface between the data and the clinician who ultimately may need to change care. So I think there's some progress there, but I'd say it's still tough. I think, you know, the other element around this that I also worry about a lot, which is, you know, we're putting more sort of detection on these consumer devices that go straight to the patient, saying, you know, we think that there's something wrong here. And then the patient is stuck of, well, what exactly do I do next? And if I bring it to my primary care doctor, they may not be that familiar with the technology. And that's where I think there's an opportunity for telehealth, you know, in both the Apple Heart Study and the Fitbit Heart Study, in the research study, when the alert would go off, they would, you know, they would have a little button that says, you know, would you like a telehealth visit now to talk about it? And they could check that they weren't having acute symptoms that need to go to the emergency room. If they weren't, then they could get a patch sent to them. So it could be all, you know, sort of expert level remote care. But, you know, when both companies finish their studies, you know, the actual product, for better or for worse, you know, that ongoing integration and who's going to pay for that outside of the research study hasn't been fully solved. So I worry that these devices are detecting things well, but we don't help we haven't fully educated the consumer, certainly haven't fully educated the providers, and, you know, ultimately the ideal would be some easy way to connect to expert level care, both the education about what to do, and then, you know, if you don't have a provider who knows what to do, you could get that care and sort of the next step in the care pathway done through a telehealth.
I actually wanted to comment on that for a moment. When I was at the payer, we were very interested in incorporating the Apple Watch into our rehab program, and we looked at it as an entry point into just beyond rehab. So here's this event, let's capture the patient, let's get them exercising, and then beyond that, sure, we know they're no longer going to be in rehab, but they still get to keep their devices. And what type of providers can we partner with, or our own care managers or our own hospitals, to allow essentially the patients, if they are having something that they want to report on, to reach out. And we actually came up with a couple of solutions to bridge that, because as health plans are always looking for that marketing angle, right? So there's a lot of incentives that we were paying out to our patients, like we were giving out Target gift cards if you did this and the other, and we just structured the rewards.
Have free dinner every week when the open enrollment period is happening.
We got them to do. We said, well, if you just actually keep, walk your 10,000 steps, and we, adjusted it based on our various patient population. We managed to make it work. So it's just about like getting that creativity. All those dollars are in marketing.
We sort of mentioned a few opportunities for telehealth follow-up for some of these things. For example, urgent care visits, or a telehealth visit to do blood pressure, remote monitoring. So we sort of started off talking about telehealth for our new patient or return patient visits, but there are these sort of smaller touch points that telehealth can be really nice for. It comes a lot down to reimbursement. But I worry a little bit about variability in what our patients are getting when they get a telehealth visit. And even in my own personal experience from healthcare I've received, it can be highly different, kind of what happens to me in a telehealth visit with one type of provider versus another. So, Craig, can you talk to us a little bit about sort of the importance of standards in telemedicine, and how AHA or maybe kind of helping think about this from a standardization standpoint?
So that's the intent of the certification, is to create some standards around this. We've already seen it. So I think there's different tiers of telemedicine. It's where I'm interacting with a practitioner that I already have a relationship with, and I have a trust level established. And then you see a second tier, which is opportunistic, may sound a little too cynical, but in the mental health side, there was a startup, and everybody who called got Adderall, and it created a whole host of, it made them a bunch of money, but maybe it wasn't the appropriate course of treatment, which is an example of why we want to have standards around mental health treatment. So, and I think primary care is going to be a little more challenging to do, but again, starting those. So the initial certifications are going to launch, and we want to add to the portfolio, and then I think the next step is continuing education around those topics.
Craig, tell us a little bit more about this certification program, or what the vision is for it, even if it's not fully developed.
So it's educational components. So you'll go through an educational modules, and then you'll take a test, and then you'll end up certified. So that's the short version.
You get a Heart Association seal, Craig?
You'll get an American Board of Telemedicine seal for it, so you'll get that for it. I don't think we've come up with a heart check mark yet, and so that may be the second tier of what we do.
What type of education, what's involved in that educational piece? What are the things that we're learning about?
Yeah, what do we have to sign up for?
So the education components are a technology component, how to use the technology and how to use the different components of the technology. And the second piece is competency. So being able to recognize things through a telemedicine visit. And then some decision trees are going to be part of it. So as you're doing the interview, there's different decision trees are a component of it.
Well, that's really great. I mean, we do training modules on, the clinical side on everything. I think every year we have to relearn how to use a fire extinguisher, but no one has made sure that I know how to use the technology for telehealth or make sure that the type of care I'm delivering is comparable. It's
consistent. You want to have some consistency baked in. And then the advantage AHA has is building into the guidelines into those processes as well. So the science and the guidelines are built into the process. And the expert panel, so it's not just all cardiologists doing mental health. The expert panels include psychiatrists and psychologists as well. So for the AHA, it's a little bit of broadening of our approach to things.
So I want to ask each of you the same question, and we'll start with Mike and then go down the end, which is, a lot of what the Heart Association does is help generate evidence. It's science, and not just from the basic side or clinical side, but really around the implementation and quality side. As we think about the future of telemedicine, where do you think the evidence gaps are? Or where are the biggest areas that we really still don't understand or need to study to really either maximize the utility of telehealth, the uptake of telehealth, or figure out how to integrate it into our system?
Another easy question. Well, I'll answer sort of from, try to answer from a more narrow perspective of how I think of this. I do think a lot about, the progress of all these consumer health, digital health technologies, but then the drop-off in impact if we don't make sure that early detection and monitoring turns into appropriate care. So I do think there are opportunities to have, I know there are some companies that sort of specialize in cardiovascular telehealth, so that you can then know that you have sort of an experience. You'd be very aware of that and potentially minimize some of the variability in care. I do think, and the AHA and ACC and a number of organizations have worked very hard to try to update guidelines, but there is often this big evidence gap between, okay, I can detect atrial fibrillation on your watch, but do you have enough to ease treatment? It's a new way of detecting. So there is one of my colleagues likes to say, a data-free zone, right? We don't have all the evidence there. So, the good news, I think, I think the AHA have been involved, and there are a number of studies, and the NIH is funding some studies to try to collect the evidence of, in the real world, if you use these new technologies, do they ultimately improve outcomes? But it leaves practitioners sort of in this difficult spot of, the data is being collected now, detections are happening now, we don't have all the evidence yet on the right path forward. And that's where, we like to lean on the AHA and other societies to say, we don't have all the proof yet, but what is a reasonable thing for everybody to do so that there is some consistent care and that patients feel like they're getting a well-grounded, authoritative viewpoint that can help as we continue to gather more evidence.
Okay, well, I'm going to come from the cardiac rehab perspective. It's a little different than telemedicine, so like in specific RPMs. So we talked a little bit about standardization. And what I frequently say, I'd be rich, I'd have more than the Powerball jackpot. Every time I say, when you've seen one cardiac rehab, you've seen one. And that's your bricks and mortar cardiac rehab. Now let's go to the virtual delivery of cardiac rehab, and the variability is even greater. But where the gap is we need people to start delivering virtual and remote cardiac rehab so that we can start getting the data and the clinical outcomes. So if we don't have the clinical outcomes, CMS is not going to reimburse for these services. So there are a lot of studies going on right now. AACVPR, ACC, AHA, Million Hearts is pushing all of these different options and innovations and technology, but we need a couple things. We need people to start doing it, and there's a resistance yet, and we need then the studies. So we've got a number of studies out there. Some good, UCSF is doing some studies led by Dr. Lexis Beatty, and we've got groups at Bay State by Dr. Quinn Pack. So there are groups that are delivering virtual cardiac rehab, but it takes time. So, this is pretty new for us in the cardiac rehab space. So we have 6-month data studies. We need more, and we need more. So until we start delivering, utilizing, and then start doing the research studies, we're going to have a gap.
I agree with everything that Barb said. There's lots of studies going on with all the different programs that are in existence. However, I want to remind us all that I think the first study, the multi-fit study from Stanford, was like in the 80s, showing that this actually works. Cardiac rehab actually does work. And I think the biggest gap from my perspective is bringing all of this to market. It's not necessarily new inventions, but shining a light on the fact that we do have an issue. Like, forget virtual for a minute. Can we just refer to rehab, period? And so I'm thrilled to be sitting next to Craig today because I think you're doing exactly what's needed, is shining a light on this issue that we do have an access to care issue and we do have solutions. We just need to sort of corral it, highlight the issue and then address it.
So we have to prove it works, both from a clinical outcome standpoint and from an economic standpoint. So one of the things our group is, so I'm a non-clinician. So one of the things I learned about research is for people to get grants, they have to have something to refer to. So we're working on a foundational paper around telemedicine, telehealth, access to care, so that people will be able to refer to things and be able to obtain grants. There's it's not University of South Carolina School of Medicine, where a guy did a study and he proved that the EMR was improved when somebody did a telemedicine visit because it was entered more quickly than waiting for the guy to write the notes down. The woman to write the notes into the record. It happened contemporaneously. So it was interesting, but it doesn't prove that improved care. It just improved that they got reimbursed faster because they could bill faster through the telemedicine visit. So I think there's a lot of research that needs to be done. I'm working on one now with Alameda County for test to treat for COVID in nursing homes. So it's not quite randomized, but we're doing test to treat in some nursing homes, and some nursing homes aren't having test to treat. So the ability when somebody tests positive to have an immediate telemedicine visit, get the prescription immediately and be treated immediately, we'll be able to compare that to the other nursing homes that don't do it. But I think we need to have a lot more research. We have to prove that it, in fact, so, the toys are nice, but we got to make sure that it all works.
And from my perspective, I have some worries about telemedicine that I would love to see more research around. The physical exam is pretty useful, and not always, but there are times where we find really surprising things when we examine a patient. And how often do we need to do that? Are we really good enough after taking a history and a telemedicine of knowing who needs to come in for an exam? Are we missing things? So I think looking at outcomes, but these are really hard studies to design. The other thing that doesn't happen as much when somebody's in telehealth are lab visits. So are we monitoring patients' potassium levels on their blood pressure medications? Are we checking their cholesterol, finding opportunities to up-titrate cholesterol medications? I think...
Could they be titrated more rapidly if they're using a telemedicine approach?
Absolutely. Are we missing vital signs if they don't have a blood pressure at home? So I think we have to be a little bit cautious about sort of having too much at home, because there is a value not just on the interpersonal side. But the other thing that I think is relevant that we don't talk about is this issue of provider burnout. And when I heard you talk about the notes faster in the EMR, it's better for billing, but it may actually be better for the provider, because then you're not at the end of the day filling out notes. On the flip side, you get a lot of joy out of the face-to-face interaction, and rather than that on a computer screen, is that decreasing the enjoyment of the physician? So I think we need to think about this in terms of what's the workload it's creating or alleviating on the physician and the nursing staff, and is it making a workforce feel more satisfied with their work, or are we sort of worsening an epidemic of burnout?
So this is anecdotal. So Intermountain Healthcare, which again is an integrated system, was an early adopter, and they were finding that 40% of the diagnoses were wrong. This is early days. And so they had to start offering a money-back guarantee that if you got a misdiagnosis, you weren't going to get charged a second copay when you came in, which I was interesting. But the video clip that I watched was a young woman who was describing essentially UTI infection. And the physician said, well, are you sexually active? The mother's standing right behind her. So guess what she said? And, so there's a lot of things that we need to think about, which, inpatient visit, they would have told the mother to get out of the room and ask the right question. So we still have there's a lot to be said for inpatient ambulatory visits, I think.
Well, I'd like to open up to the audience. If anybody has questions or comments, we have a mic over on the floor, and so please do come up and join us on the discussion. Either share, ask the questions that you have around telehealth of the panelists, or share any thoughts or comments that we may be able to reflect on.
Hi,
I can relate that mic is set up for Pat, not for you.
I need 1 foot down. Can you hear me? I have a question for Dr. McConnell and all the panel. Basically, speaking of telehealth and expanding it to cardiac rehabilitation, and as we all know, rehabilitation is a special type of tele-monitoring, and what are your thoughts on going ahead with CHF patients using for cardiac rehab virtually, when, as you know, the technologies like Navar exist for allowing virtual ECG monitoring for such patients?
Yeah, well, so I think just to repeat, you're asking about sort of broader use, including heart failure for cardiac rehab, particularly tele-cardiac rehab. So, right, historically it was sort of started after bypass surgery, and then it's gradually expanded, but as you know, one of the highest rates of rehospitalization out there, the biggest burdens for a lot of healthcare systems is heart failure, and so it is, it's reimbursable for heart failure post admission cardiac rehab. So it would be an ideal use case. I think we did do between ACC and the Consumer Technology Association, we did a guidance around a lot of the technologies, and we highlighted some examples, and cardiac rehab was one of them. My co-chair actually had written a piece on sort of tele-rehab during COVID, how that had grown has been highlighted. But I think one of the challenges around cardiac rehab that sort of, if you think mostly in the device world, you're sort of missing probably half of what cardiac rehab is about, which is there's something, you can correct me, there's something like 12 or 13 elements of cardiac rehab that are supposed to be addressed, that the technology piece probably does fewer than half of that number. And so that interpersonal connection and the interaction is going to be critical for that holistic approach.
My question was not about replacing the whole cardiac rehab with just an ECG monitoring, but allowing CHF patients to do virtual cardiac rehab with ECG monitoring.
Sure. Yeah, no, I think, my understanding
at this time, I think people are scared of, and I heard a lot of places, oh, we don't want to do high-risk patients for virtual rehab. And they just stay away, whereas I hear that the population is about 40% who qualify for cardiac rehab, which is...
And no, post-hospitalization heart failure is an indication for cardiac rehab, and I mean, you're right, there's sort of this irony. They are at high risk for rehospitalization, so even more the reason they should be getting cardiac rehab, but there's probably concern. And anyway, I'll let
As an
cardiac
economist, CHF is the #1 DRG in the country.
Right.
So it's the most expensive thing we deal with in our system. So that's a good case example. If we could figure that out, we could really save money within the system. But I think that there is, so most of the focus is on post-MI or post-CABG rehab still. And the traditional barrier was you had to have physician supervision during physical cardiac, and so still do. And so I get back to the barriers. There's a whole advocacy issue. So there's going to be an advocacy issue around CHF rehab. There's still an ongoing one around cardiac rehab, traditional cardiac rehab. So there's a lot of barriers that we still need to deal with.
But heart failure right now, if we right now in traditional cardiac rehab, we see about 29% enrolled, that are eligible, that are actually enrolled. In heart failure, it's about 4%.
It's miserable.
It's terrible. So we have to figure out a way how to treat those patients.
So there's my co-chair, Ritu. Thanks for chiming in.
This is such a great discussion and panel, and thank you to all of you. And to echo the last comment, in Pennsylvania, another barrier that they've just created is that you need to have, if you see a patient via telemedicine, then you need to have them sign on the dotted line a piece of paper within a week. I mean, that's another barrier. It's ridiculous, right? So anyways, my one question I have for you is on workflows. So when we have telemedicine workflows, when we started in COVID, we just picked up based on in-face visits. And we haven't really mastered, the kind of workflow questions and sort of the triage, I think, that would make us all feel a little bit more secure. Maybe there's outcomes data that would follow along with that.
So the mental health folks have done a much better job, and that's what we're trying to translate into these other certification programs. So the mental health is pretty mature around the triage process and have good rigor around it. So it does need to be incorporated into these other things that we're going into. I completely agree.
And kudos to the discussion on cardiac rehab, where certainly women, minorities, I mean, maybe I missed that discussion, but we're really at a loss there with such good evidence that it works. Thank you.
Absolutely. I wanted to just answer the previous question that was asked. We actually have 25% of our patients are actually heart failure patients in certain populations where payers have said to us, we're very interested in our heart failure patients. So it can be done, and there's a lot of discussion around medication titration and how sophisticated do we want to be around that and all of that. But we are seeing heart failure patients.
Well, I think, Dr. Greg Fonerill's been, the 4 pillars and rapidly to treat. And I think there's reluctance in the outpatient setting to do it because of the titration and the monitoring that needs to take place. So, the more the better in that case, I think, around CHF, not just the rehab, but the actual treatment of CHF in the outpatient setting.
Another question.
Hi, thank you for the presentations. My name is Noor Shuman. I'm a research fellow at Tulane University, and I'm kind of in the beginning of my career. I've been a research fellow for 7 months, and I'm really interested in primary healthcare and cardiovascular risk factor modification. And I know how important, obviously, digital health is, and the digital technology tools are necessary to achieve those objectives. So. I'm wondering, so Dr. Craig, you were mentioning...
I'm not a physician, I'm a finance guy, so keep going.
Yeah, it's just a habit, I'm sorry.
That's all right.
Okay, so you were discussing...
If you have a heart attack, though, I know CPR. So.
Hopefully not. So you were discussing different modules that are educational modules that are going to be available for physicians and healthcare providers to provide us with the necessary skills and knowledge base to become specialized in providing digital healthcare, right?
Correct.
So I wonder when part of the specialized training in this field is going to become a part of a medical curriculum for residencies, and because that would be something I would really look forward to to receive as a training, to become a specialist and to be able to have the necessary knowledge to be specialized in providing telehealthcare and digital healthcare for my patients in the future. So I'm wondering when this can become a reality.
So a staff person's going to grab you after you sit down here. But I mean, that's a good question back to Mike and Anne-Marie is, you know, you're the academics, when is this going to get incorporated into the curriculum? You know how challenging that already is.
I can make one comment as my daughter's first year medical student, so I brought her here to the Health Tech Pavilion on Saturday because she's in medical school here in Chicago. It is interesting, I had a discussion that they were still having her buy a stethoscope that was not digital, that couldn't record anything, that's not connected to anything, and that just blew me away. Whereas you have other
buy them here, I think in the exhibit hall.
Yeah. And but there are other medical schools that are handing out, butterfly connected, ultrasounds to replace the stethoscope. So we're in this complicated transition point. I mean, I think the AHA's effort initially is around telehealth specifically, but you bring up a good point. How do we also teach more broadly about digital health and these tools that are sort of rapidly evolving? But there is hope that
Stanford's certainly at the leading edge of digital world, so
yeah,
not to disparage UT Southwestern.
No, I think on this one, I'm actually thinking that this is going to be an area where we learn from the generation below us more than we teach the next generation. I don't think that the old crusty doctors that barely got used to using the EHR are the right people to teach people how to use the EHR and do televisits. I think we need innovative new researchers like you to help develop the systems of care. What we did is, I think, as Ritu just mentioned, what we did is we just took our current clinic templates and said, now this is telehealth, and here's your video on the same EHR. But I don't know if that's the right process. Should we not have somebody calling and doing all the med recs together, teeing up notes? Like, how do we? We tried to push telemedicine into the shape of the hole that we had already, which may not be the right way to do it. So I think we need disruption, and I actually think that it's the next generation that's going to provide that disruption, because you're not as influenced by the sort of inertia of this is how we've always done it. So I'm thrilled that AHA is doing this with the American Board of Telemedicine. I think standardization and certification is important. That's table stakes to provide comparable care than we have now. But I think telemedicine has the opportunity to really transform how we deliver care, start to impact, improve blood pressure control, lipid control, utilization of guideline-directed medical therapy. We haven't figured out how to do that with our current clinical model, and we need a new clinical model to do that, and there's no way it's going to all be in-person visits in the clinic with our patients in the future.
And I would say one of the reasons AHA took it on is it's not on the radar screen. So I also sit on the American Board of Internal Medicine. I'm not a physician, but
you just play one on TV.
Thank you. I stayed at Holiday Inn Express. It's not on their radar. I can guarantee you it's not on their radar screen at all. So I think it is an imperative that somebody picks this up and takes it and starts running with it. I think it'll look very different 5 years from now than how it looks today.
It's one of the reasons that, I've probably said on a few of these panels, I'm a big fan of the concept of digital therapeutics, because it bridges the gap a little bit of how people think that, if you're going to offer any kind of health intervention, you want to think of it as a therapeutic. Means that you're trying to change an outcome, and you should be taking it through the FDA to prove that you can change an outcome. And then it should be something where you can then click that order in Epic just like you order a test or order a drug. We're just at the beginnings of that, but I think that's part of how we sort of bridge this consumer to clinical world.
Well, this has been just an amazing panel. I'm just, wondering, any final thoughts maybe from Barb or Zainab as we close out?
I was going to say for the lady who brought it up earlier that one of the things that it's not just about everybody needs access to things like rehab and access to care in general, but I think we have to, pay close attention to women, minorities, people that are not getting these services, and just going back to, again, really thinking through from a systematic standpoint, how can we leverage telehealth so that it's just standard, we don't have to think about it, everybody gets this, and we're not, focused, oh, did we think about the woman, did we think about this person, because they have that, just standard.
The other thing I would add is, so AACVPR, which is our National Association for Cardiac and Pulmonary Rehab, we certify programs. They go through a certification process. Those are our bricks and mortar programs. And they're just starting now to look at how could we certify a virtual cardiac rehab program. And so I don't know how long that's going to take, but it will take some time till we get to that.
We should send Craig to them.
Yeah, Craig, could you do that?
Well, just to wrap up.
I was just, my last comment was just going to be, I don't believe that telemedicine or virtual care will ever replace the providers, but it will, if done right, will enhance the care and the patient experience.
Well, speaking of access to care, I mentioned earlier I'm the volunteer lead for Doctors with Heart, and we're going to close out with a video talking about what Doctors with Heart is. If there's cardiologists out in the audience that want to join us, we hope you do. This is a labor of love. Our lead AHA worker is Cassie Walker, sitting in the audience. Hello, I'm Dr. Anne Marie Navar. I'm a cardiologist at UT Southwestern Medical Center in Dallas, Texas. I'd like to talk to you about Doctors with Heart, a program that brings cardiology support to people who need it via telemedicine. We're all concerned about disparities in healthcare access and quality that affect under-resourced communities. People in these communities are more likely to face chronic diseases such as cardiovascular disease and experience worse outcomes, but have access to fewer resources to support their treatment. Many also face barriers to care such as lack of insurance or transportation. Smart, cost-effective use of technology can help us close these gaps. Doctors with Heart was inspired by the virtual consultations that I arranged with clinicians, including my own parents, who volunteered at a community health center in South Texas. This program expands that experience by enlisting the tremendous resources of the American Heart Association. Its thousands of professional volunteers include many cardiology specialists willing to engage in free doctor-to-doctor consultations. These volunteer cardiologists tackle a wide range of topics, from coronary artery disease to heart rhythm problems such as atrial fibrillation, heart failure, and many others. The Doctors with Heart process starts when a patient visits a federally qualified health center or other community clinic that's participating in this AHA program. A health center clinician identifies when a peer-to-peer cardiology consultation would be helpful. The clinician schedules the online consult between the clinician and one of our volunteer cardiologists, either live or via web chat, and provides documentation via a secure portal. Importantly, the provider and health center always remain in control and responsible for the patient's medical journey. I invite you to join us in this effort to improve cardiology care for everyone. For more information or to volunteer, visit heart.org/doctorswithheart.
And just, this is not, Anne-Marie has been working in communities that have had difficult access to care for her entire career, so I know that this is a passion for her. So anybody who's here that wants to sign up, I'm sure she's willing to talk to you afterwards too.
Well, thank you to our panelists and thanks to our audience. I hope everybody has safe travels home from Chicago.
Take care.
Hello, I'm
Dr. Anne Marie Navar. I'm a cardiologist at UT Southwestern Medical Center in Dallas, Texas. I'd like to talk to you about Doctors with Heart, a program that brings cardiology support to people who need it via telemedicine. We're all concerned about disparities in healthcare access and quality that affect under-resourced communities. People in these communities are more likely to face chronic diseases such as cardiovascular disease and experience worse outcomes, but have access to fewer resources to support their treatment. Many also face barriers to care such as lack of insurance or transportation. Smart, cost-effective use of technology can help us close these gaps. Doctors with Heart was inspired by the virtual consultations that I arranged with clinicians, including my own parents, who volunteered at a community health center in South Texas. This program expands that experience by enlisting the tremendous resources of the American Heart Association. Its thousands of professional volunteers include many cardiology specialists willing to engage in free doctor-to-doctor consultations. These volunteer cardiologists tackle a wide range of topics, from coronary artery disease to heart rhythm problems such as atrial fibrillation, heart failure, and many others. The Doctors with Heart process starts when a patient visits a federally qualified health center or other community clinic that's participating in this AHA program. A health center clinician identifies when a peer-to-peer cardiology consultation would be helpful. The clinician schedules the online consult between the clinician and one of our volunteer cardiologists, either live or via web chat, and provides documentation via a secure portal. Importantly, the provider and health center always remain in control and responsible for the patient's medical journey. I invite you to join us in this effort to improve cardiology care for everyone. For more information or to volunteer, visit heart.org/doctorswithheart.